Okay, everybody, going to start talking about ultrasound for ascites and what to look for in the abdomen to identify this condition, and also how to guide its drainage. So, speaking of crystals, you know that there are a bunch of crystals lined up here in the transducer, transducing electricity into acoustical energy. And here they are lined up here, and there's one here that gets electronically steered, but curved probe, linear probe, phased array probe. Usually this is for the heart. It's got low frequency, penetrates deep into the body. This is for structures that are more superficial, high frequency, really pretty images, but can't penetrate very far. And this has like 128 elements lined up in it, crystals lined up in it. It makes very pretty pictures. And so when it comes to ascites, if I had my druthers and the patient was pretty thin, I would go for this one, especially if I'm not just diagnosing, but doing the ultrasound-guided paracentesis. This is a good way to go. But if they're larger, which a lot of patients tend to be, this is the one you're going to have to go with a lower frequency. Now, you can definitely get away with looking for ascites with this one here too, but if you've got this one, it makes such a pretty picture, I would go with that. So the majority of the time, I'm using that large footprint curved probe in that 2 to 5 megahertz range. Just keep in mind the indicators. Just a reminder, the indicators are right there. On every manufacturer does it differently. This manufacturer happens to put a line there, a little ridge that you can feel. And on their phased array probe, they have a light as well where the indicator is. So that's even more helpful. These little ridges over here, you know what those are for? Good. Those are for guides, exactly. So if you were to snap on a guide, a needle guide, to guide the needle into a particular location. But we're going to talk about needle guidance, but not going to use snap-on guides. But just don't ever forget that the probe doesn't know where, the machine doesn't know where the probe is. There's no gyroscope in the probe. You would think there would be, but there is not. You are the gyroscope. You have to be very mindful where the indicator is, especially with all this ultrasound-guided procedures. So you may have heard of this, the UCI 30, the 30 things that UCI medical students hopefully can do with ultrasound by the time you guys graduate. If you never heard of it, it's in the 2014 Academic Emergency Medicine in July. But basically, looking throughout the body with ultrasound, one of the things that that Stanford 25 talked about was the stigmata of liver disease with the physical examination, looking for angiomas and diminished armpit hair, breast enlargement in a male. These kinds of things are what you look for on the physical exam. But with ultrasound, we can actually look and see signs of inflammation and even screen for things like ascites very early on, way before you can see it on the physical examination. So that's why ultrasound's helpful. And then talked about liver percussion to assess how large it is. Maybe you can feel some nodules and masses on there, or how tender the area is, and certainly all those things can be identified with ultrasound as well, including illicit tenderness. Now, when it comes to ascites, this is another thing that the Stanford 25 really focused on and brought up that you look for buildup of fluid in the abdomen around the organs, and that's of course goes hand in hand with liver disease. But other things you can also see it with heart failure and ovarian cancers. And again, they talk about a percussion technique, but we basically have a standard now of care, which is to always look with ultrasound to confirm the patient actually has ascites before doing a paracentesis. Because you can get somebody and you're thinking to yourself, they probably have, like this guy, like really bad ascites, or he's just like obese, or something else is going on, like a small bowel obstruction. Now, he's smiling. He looks pretty comfortable here, pretty happy. I don't see the other signs of liver disease here, the other stigmata of liver disease. So I bet this guy's just obese. But you never know, and that's why we turned to ultrasound. So what can ultrasound see? Ultrasound can see a small bowel obstruction. So if you saw this and someone told you, oh, that person's got ascites, go do a paracentesis, and you walk in there and you see this is a small bowel obstruction. These are dilated loops of bowel here. You would not want to put a needle into this bowel causing an enterotomy. That would mean a trip to the operating room to repair. So don't do a paracentesis on patients with ascites. Patients with small bowel obstructions. You're actually looking for this. You're looking for ascites. And you can see here loops of bowel here floating in all this fluid. Now, there's exudative effusions and transudative effusions. I'm sure you're learning all about the difference in your class, but I won't get into too much of that, except on ultrasound. It's kind of cool. If you see all this debris in there, that's more likely to be an exudative effusion versus a transudative effusion is completely jet black anechoic. The majority of time when I see ascites, at least in the emergency department, they're all transudative effusions. Rarely we get to see a really interesting exudative one here, seen with all this debris. Usually it's all jet black anechoic. Now, what about this? This patient had a distended abdomen. They had some jaundice. We are thinking they had some kind of obstructive process going on, and we're looking for ascites, but instead we saw all these tumors in here like liver cancer. You can see how the liver here looks very different than all the livers you've been looking at in your clinical foundations course on your healthy models. These livers, this is a liver here that looks markedly different with all these focal areas of hyper and hypoechogenicity, which is cancer liver. Whether that's primary cancer or metastatic disease, don't really know from this. Of course, that's where biopsies come into play and things like that. Now, here's another reason why somebody might be distended, because their intragastric contents, they've got a lot of intragastric contents there, and it's causing abdominal distension. And so this is a patient, you can see this is just fluid in the stomach. There's a bunch of air here as well. Maybe they just beer bonged a really, carbonated beer, I should say, and it's causing all this air fluid and stuff like that. And they just really, all this air needs to rise up and they need to have a belch. I don't know, but this is definitely a stomach full of fluid. Now, here's an example of somebody who definitely has a small bowel obstruction. You can see what we call the to and fro of peristalsis, aka the poo and fro of peristalsis. Very clever, I know. This is the bowel obstruction down here. This up here is all the ascites, and you can see this typical transudative anechoic jet black fluid up here, maybe a loop of bowel sort of hanging out in the midst, and you can see just the fluid just kind of gathers dependently if the patient's lying flat. Posteriorly, if the patient's standing up, it'll go all the way down into the pelvic gutter. But you can see here, this is all just ascites. And if you were to do a paracentesis, pretty easy to do. You want to avoid the loops of bowel in your ultrasound guidance, which I'm about to get into. This patient's got some ascites, and you can see there's loops of bowel sort of peristalsing along here. And in between those wedges, those sharp angles, that's where two loops of bowel sort of come up next to one another. You get these sharp angles here. And the anechoic fluid seen between the sharp angles of peristalsing bowel is what ascites, or at least fluid within the intraperitoneal cavity, looks like. Now, if this patient had just gotten into a car accident or was stabbed or had some trauma, when I see fluid between these loops of bowel, people say, can you tell the difference between blood and ascites? And the answer is usually no, particularly acute bleeding that's very jet black anechoic. Once blood crashes out of solution, becomes a coagulated mass, it gets more dense and therefore it looks more echogenic on ultrasound. But acutely, blood and ascites look identical. So, in this patient here, they had the stigmata of liver disease, and this indeed was ascites. Here's an example here of some ascites seen down in the pelvis. This is the uterus right here. This is the ovary over here. This patient did have ovarian cancer and had some localized ascites around this region over here. You can see the bladder is seen in this particular location here, and there's all this fluid down here posteriorly, anteriorly, posteriorly. Lots of ascites here. And here's just a tiny amount of fluid seen here peristalsing in between these wedges of fluid, these loops of bowel and sharp angles and wedges here of the fluid in between them. So even on this machine, by the way, this machine is like 20 years old. This is an old BK machine that we had back when I first got my job at UCI. And so, but once in a while it made really pretty images, and I still like to show them off. Sort of vintage ultrasound right here, throwback Thursday, except today's Friday. So here's some pelvic ascites. This is, you see all this anechoic stuff here in a transverse plane. Oop, there's the bladder right there. And then as we fan past the bladder, we see all this ascites. They even wrote on the screen ascites here. So again, there's as you're fanning through it, I'm going to freeze it right here so you can see the bladder. This is this rectangular shape, relatively empty-ish bladder here. The structure behind it is either prostate or uterus. It's looking a little bit like prostate to me. and that prostate will be larger in older male individuals. Now, as they fan through that, I'll pause it right here. Now they're more superior than the bladder, and you can see all this fluid here, maybe a loop of bowel sort of hanging out. But what a nice location to drop a needle in to do a paracentesis. Okay. And sometimes, this is the last clip I'm going to show you. Here, sometimes you get these little loculations. Loculations is a fibrous stranding of material that's within the intraperitoneal cavity in somebody who's got usually chronic ascites. Maybe there was an infection that happened a while ago, and some of this fibrous, sticky stuff got laid down, and then it appears like that. So I'll let this video clip roll, and you can see how these loculated ascites are beautiful. As you kind of push down on the abdomen, you can see the ascites kind of float around and stuff. Again, this is a very old machine, but I just love these loculations in here. Under ultrasound guidance, you can guide the needle into one of these loculations and try to drain them if you'd like. However, you want to make sure you don't actually perforate a loop of bowel, because sometimes they do look like what's a loop of bowel versus what is a loculation. It's something you just have to be extra careful about. All right, so what are the indications to actually drain this fluid? Well, there's three main indications. Number one, that you think that the patient could have peritonitis. And so spontaneous bacterial peritonitis, they usually have the clinical signs of that, like tenderness on the abdominal exam. When you're looking for ascites, the patient's complaining as you're moving the probe around, and they're withdrawing their legs and in pain. So there's that. And they may have a fever, and they may have a white count. Evaluation of new ascites. And so somebody who's never had ascites before, a healthy person comes in and suddenly there's fluid seen in their intraperitoneal cavity. We need to find out what's causing that. And ruling out a malignancy is one of the things we do when we do a paracentesis in that situation. Or in somebody who's got chronic ascites and they have these large fluid collections, what happens is it ends up pushing up on their diaphragm so much, and their abdomen gets so distended, it's like a drum. It's like tight as a drum. It's like that picture, that first picture you saw on that guy, except without smiling. They're usually very uncomfortable, very dyspneic, and you can see they've got the stigmata of liver disease. And those patients, they're basically breathing 40 times a minute, and you draw off 4, 5, 6 liters of this acidic fluid, and suddenly they can breathe again, only to have it return a week later. So a lot of patients rolling into primary care clinics and into liver experts, hepatobiliary experts, and you can imagine how many come into the ED for these drainages as well. Now, there's some contraindications. The most absolute contraindication, I would say, is a surgical abdomen. If somebody's got tenderness and it looks like they need a trip to the operating room, they're so tender you can't even palpate them without them screaming. It's an acute abdomen or surgical abdomen. That patient just needs to go to the operating room, and it's not time to start messing around with paracenteses. But that's rare. Usually what we're talking about is something like this. If somebody has a platelet count less than 20, somebody who's coagulopathic, INR greater than 2, not to say you can't do it on these patients, but definitely think twice about it. How indicated is the procedure? Somebody who's so tense ascites, they're like a drum, they can't breathe, they're breathing 40 times a minute, I'll go ahead and take my risks on somebody like that because I want to control their breathing first. But if I'm doing it diagnostically, just to see why they have ascites, you might be able to correct some of this stuff first. Somebody who's unable to coagulate from DIC, somebody who's got fibrinolysis, somebody who's pregnant, you need to be, of course, very careful when you put a needle through their abdomen. Somebody who's got large distended urinary bladder, it's probably a little safer to avoid that bladder content first so you don't harm it as you're doing your paracentesis. Cellulitis, you don't want to push a needle through cellulitis because you could cause the bacteria to go into the abdomen and actually cause bacterial peritonitis then. And somebody who's got a lot of loops of distended bowel or small bowel obstruction or who's getting there with their ileus. And then adhesions, intra-abdominal adhesions. And maybe you saw some of those loculations, but if they're so tacked down with so many adhesions, that's something to consider. Now, there's been a couple of publications on this. One of them I thought was interesting. I was kind of poking around the literature a minute ago, and I found this paper from 2018 back in the day, if you're watching this podcast in the future. Basically, hey, you know what? We should do this as an outpatient. Why send them to the emergency department when they can get this done as an outpatient, especially if we have ultrasound guidance? And because, for years, ultrasound was like hard to train people in, and nobody knew how to do it, and the machines were $300,000, and they weren't portable, so you couldn't like go to somebody's house. You couldn't really have it out in the outpatient setting, in the clinic setting, in a helicopter, out in rural areas, critical areas. All these patients were getting blind paracenteses, where you just take a needle and you go, you know what? I bet this is a good spot to put the needle. I know, right? I know. I feel the same way. So, yeah. Hey, why not? Let's do it under ultrasound guidance, and we can do all this as outpatients, including, the nurse practitioners and everybody else. So how about this one here? There's another article. I only have two. This one's from Mexico. Pocket ultrasound device as a complement to physical exam for ascites evaluation and guided paracentesis. So they said, this pocket ultrasound device for ascites detected it like 95% of the time. And these were, again, pocket ultrasound. I get this question on the daily. How good are those pocket ultrasounds compared to a regular ultrasound? And we need more and more studies like this to show that they are, adequate. So ripe for research, especially with all the new pocket machines becoming very affordable and ubiquitous. So where do you stick a needle when you're going to do a para? There's three main locations, midline or in these lateral areas. And so kind of right underneath the umbilicus. Of course, the urinary bladder is right around this region here, so you got to, be a little careful there. Laterally, here or here, this is the inferior epigastrics here, and you need to be very mindful. Mind the inferior epigastrics, because that has been known to be quite a cause of complications in patients with getting paracentesis, because after all, you're legit taking a huge harpoon. I mean, it's like a foot-long needle, no joke, that we are pushing this long catheter all the way into their abdomen, past all the abdominal fat and everything, three-way stopcock, and then we're going to hook up this tubing to it, take the needle out. Now it's just a catheter in there, but you got to drive the catheter in there somehow. Use that giant harpoon to do that, and then this drains out the ascites here. And you can see this. This is a typical color here for ascites. It's that kind of, ironically, it looks a lot like beer to me. But anyways, so there's two ways to approach any needle localization technique. And this is not just for ascites, but this is for like vascular access, foreign body retrieval, whatever you're trying to do. When you're guiding a sharp object into somebody's body, you can do it under ultrasound guidance. And there's two ways. One is called in plane, and one's called out of plane. Now, what that means is in plane is here's the ultrasound beam coming down of your probe, and you take the needle and you stick it underneath the entire beam of the ultrasound. That's in plane. You can see that needle tip and the entire shaft of the needle, and you can reposition, and it looks beautiful. The other way to do it is out of plane technique. Out of plane technique is where you're going to just see an artifact on the screen that is not just the needle. It's not the needle tip and the whole shaft. It's actually just some part of the needle, whether it's the tip or the shaft. You don't really know unless you start fanning this probe back and forth and waiting until this artifact goes away. If the artifact goes away and then it comes right back on again, you go, oh, that's probably where the tip is. And then you can slowly advance that tip, following it down as you fan through it. Another way to do that is, and this is what's happening here. This is the out of plane technique, and it's a bit of an issue because you don't know where the tip is as you're advancing. If your target's over here, as your needle's coming in out of plane, you can fan it, and then you can follow it right down. Now, I know it sounds like I'm being really negative about this out of plane technique, and I know that in plane looks beautiful, but this technique is actually very effective once you get good at it, and it does have some advantages, especially with vascular access, with regards to being able to see both the artery and the vein at the same time. And there's some other issues with vascular access that make this technique usually the go-to when you're starting the procedure. But just to show you how it's done, you kind of fan back and forth. Another way to think about the out-of-plane technique is the Pythagorean theorem. That's right, I said it, the Pythagorean theorem. This is the a squared plus b squared equals c squared, the right triangle. Here's like the skin line, and this is the, say, target down here. The same distance that the sound needs to go down to the target, X, should be the same distance, X prime, that you choke back away from the center of the probe so long as the needle comes in at a 45-degree angle. So in other words, if your target is 1 centimeter, let's say 2 centimeters deep, and you're going to choke back 2 centimeters away from the center of the transducer, coming at a 45-degree angle, and as you advance, eventually, your needle tip should reach the target and the sound at the same time. So that's one way to think about the out-of-plane technique. The other way is this fanning business, trying to find the tip as you're advancing the needle. Somebody told me a cool way to discuss this the other day. I forgot it now. My fellow, John Muller, he said, oh, we call that the bump and grind or something. It's not bump and grind. That's weird. No, it's something like that, though. It's like walking the dog or walking. I don't know. I'll think of it later, I'm sure, and I'll remember. Okay, so here we are. This is an out-of-plane technique. And we're doing a para. The loops of Bowel way down here. This is my old school machine from the 90s. And you can see, even on this old school machine, we get a pretty good view here of this needle tip artifact. There's a ring down artifact coming down, reverberation artifact. Needles really make a lot of noise on ultrasound, which is beautiful because we can see them. But this is, again, out-of-plane technique, and we're shooting for this region over here to do a paracentesis. So here is the large footprint curved transducer with all those elements here. This is skin line here. This is some fat. Maybe some muscle, some muscle here. And then this is the peritoneal lining right here, okay? And this is like bowel down here's a loop of bowel. Doesn't really look like bowel, does it? But this is normal loops of bowel. They're just nice and floppy and compressed. Now, when I start the clip, all this black stuff here, all the anechoic stuff, that's all the ascites. What you're going to see is this needle trying to punch its way through the peritoneal lining. So this is all the peritoneum here, and the needle's like trying to get through it. And they're having a tough time getting that needle through there, but they're doing it in the in-plane technique. Try not to touch the bowel. No, back up. Go over here, please. So you can see that's the technique here. You can like guide it in. And why is it having such a hard time getting through this peritoneal lining? Well, when we were all doing these things blind, we never really knew where we were. We're just kind of poking and poking and poking. But now that we see them in ultrasound, especially patients with chronic ascites, this peritoneal lining's been poked so many times it gets very fibrous, very thick, very difficult to punch through. So in the in-plane technique, you can line it up and then just drive it over this way. That's probably what I would do next. Here is another example of in-plane technique. As you can see here, we're using a different transducer. We're using that high-frequency linear probe, HFL. Beautiful images here. Here's our needle coming in. This is the tip of the needle here. The peritoneal lining is here. We can see some skin, fat, muscle. And these are, let's see, 1, 2, 3, 4, 5, 6 centimeters. Okay, so from skin line into the body, 6 centimeters. So let's see, 1, 2. So this is like 2 centimeters. And then you get fluid. So think about that for a minute. On your own abdomen, 2 centimeters, and then you're in the peritoneum, that is a thin person. Therefore, they're taking advantage of that by using the higher frequency linear probe. And it just makes such a pretty picture. Here's the video. And you can see how the sound is like lined up right with the needle. This is all ascites down here. They're kind of fanning back and forth. That's the needle tip. You can see the bevel is up. You can see the bevel being up right here. This is loops of bowel down here, some reverb artifact coming off that needle, and they are in the right location for sure. Here's another example here for linear transducer, doing an in-plane technique. It's kind of hanging off the screen here. I might move the probe slightly that way in order to get a little more real estate over here, but you get the idea. The needle shaft and tip is coming in here. This is all loops of bowel down here. This is all your ascites right here. Again, we're looking at about, this patient's got maybe 2.5 centimeters of skin, fat, muscle, and then needle. Cool. So what do you got to worry about on these patients? You got to worry about the inferior epigastrics. So this is sort of a confusing diagram. Let's see if I can figure it out here. This is the umbilicus. Oh, I see what they did. Here's the umbilicus, and they basically like cut this open here, this flap right here, and they like yanked it back so you can see how the inferior epigastrics like cruise up here and perforate and go into the, probably this is the rectus sheath over here. Yeah, this looks like rectus over here. So you gotta be careful. You gotta be very careful. These inferior epigastrics. This one's really, so this one's really superficial. you can see here, and it's on top of the rectus, and they're smaller caliber, not as big of a deal. But boy, you'll nail one of these inferior epigastric vessels, especially in somebody who's coagulopathic, has low platelets. You're gonna cause a pretty big complication, or possibly even exsanguination and death. So you got to be careful. You got to use ultrasound, and you got to look for the epigastrics. So here, this is what they look like on ultrasound. Here's a inferior epigastrics here. They are no joke. There's some big caliber vessels. You can imagine if you put that needle right in there, and somebody who's coagulopathic and has thrombocytopenia, you would, really set them up for bad news. So this is the peritoneum. This is somebody who does not have ascites. I think we're just kind of messing around, showing where the inferior epigastrics are using color flow Doppler. So if you wanted to do that, you could use a little color flow and just say, okay, there's my inferior epigastrics. Cool. I'm going to stay away from. You could even map them out, draw on the skin where they are. If you wanted to, if you had some time and you weren't in a rush, you could easily just drag the probe down, and you can just mark on the skin with a marker and just, give them a little temporary tattoo, and then you'll know where to go. But that's basically it. That's how this works. Ascites, paracentesis in a nutshell, and hopefully you guys get some chances to do this when you're in the third year of medical school. Certainly, we do a lot of these in the ED. If you do your ED rotation, there's a high likelihood in your fourth year that you'll get a chance to actually perform one of these. Particularly if I'm working, I like to let you guys, assist me in these procedures, and we have a good time teaching and advancing the needle and stuff. So that's about it. Thank you very much. Looking forward to seeing you guys soon.